If you're 70 and you're having recurrent UTIs, is it too late to start vaginal hormones?
It's never too late to start vaginal estrogen therapy, which is such a great thing for me to be able to share with patients because there is such a fear around hormone therapy. But when it comes to vaginal estrogen therapies, we know through lots of excellent literature and data that the amount of estrogen in those products is so minuscule that there really isn't any significant systemic absorption. So if a woman was to start some form of estrogen therapy for her vaginal symptoms or urinary symptoms, did a baseline estradiol level, repeated it again at 2, 4, 6, 8, 10, 12, 1 year, the number would not increase. And so that really, really does give us as healthcare providers the comfort in telling patients that this is not going to cause a stroke or heart attack or a blood clot, that the amount of estrogen in these products are so low that they don't even enter into the bloodstream.
Shafeena, welcome to the podcast. Thank you so much for joining me. I know I've literally grabbed you and you didn't have much time to even think about it, but thank you for saying yes. I would love to talk to you about the Genitourinary Syndrome of Menopause and all of what that encompasses for our patients. And I wonder whether you could, first of all, let me know, what actually is that?
So actually, even before we talk about the Genitourinary Syndrome of Menopause, we need to go back 10 years and understand the history. So before that term was coined, which was actually in 2014, it used to be called Vulvovaginal atrophy. And so what I tell to patients as they are entering into menopause and trying to understand some of the symptoms that they may or may not be experiencing, I help women understand that there are estrogen receptors throughout our body. Starts in the brain. We have estrogen receptors in our bones, in our heart, in our skin, in our muscles, in our breasts, in our uterus, and then also in the vulvovaginal area and the urinary tract. So before 2014, there was this knowledge of vulvovaginal atrophy, which is essentially a drop in estrogen levels, specifically in the vulvovaginal area. But it didn't really encompass all the other areas in the pelvic area, so the urinary tract, which includes the bladder and the urethra. So, and the word atrophy really comes from a negative connotation because it sounds like it's shriveled up and dry. And so the North American Menopause Society in 2014 decided that in order to expand the understanding of what happens to women in terms of the drop in estrogen levels, not only in the vulvovaginal tract, but also in the bladder and the urethra. And interestingly, all of those structures come from the same embryologic origin. They then decided to call it the Genitourinary Syndrome of Menopause. And that encompasses the vulvovaginal symptoms, the urinary symptoms, as well as that effect on sexual function. So that's really what the Genitourinary Syndrome of Menopause is. And each component of that has a different phenotype.
So can we talk through those three sort of subsets and talk through what our listeners might be experiencing, or they might have a friend or family member experiencing? So maybe we can start with the vulvovaginal symptoms.
Mm-hmm. So I give patients an analogy in the clinic, which might be a little bit hard to hear, but it really does help them visualize what's happening to their vulvovaginal area. So I talk about either a succulent grape or a pleated skirt. So that is premenopausal. The vagina is lubricated. It has ability to secrete. It can accommodate. It can stretch. There are rugae there. It can birth a baby. It can be functioning for sexual intercourse, and it's well estrogenized. And then when a woman enters and then proceeds into menopause, the succulent grape turns into a shriveled up raisin or a tight pencil skirt. So the tissues become very thin, very pale. The ability to have adequate moisture and lubrication ceases, and it becomes very tight, irritable, and intercourse can become very painful. So those present for women with vaginal dryness, burning, irritation, and pain with intercourse. So that's sort of the vulvovaginal presentation.
Okay. And then let's talk about the bladder side effects.
So the bladder can present differently. For some patients, that can be increased urgency and frequency. So that basically means that you all of a sudden have an urge to go to the bathroom and you're sort of trying to get there. You may even leak a little bit of urine. Frequency meaning the desire or the feeling that you need to go void. But when you get to the toilet, you just don't have a lot of volume there. There's also some stress incontinence, which sort of is more so related to aging than specifically the loss of estrogen. A lot of patients also tell me that now all of a sudden they're waking up and using the bathroom in the middle of the night, which can be very disruptive if they are also waking up with vasomotor symptoms or night sweats. And then there's also a tendency for women to start having more urinary tract infections. So we know that when you are estrogenized in your vagina, the pH of your vagina is more acidic. And as you enter and proceed into menopause, it becomes more basic, the lactobacilli drop, and there is a more chance of urogenital bacteria to enter into the urinary tract, and that's how more urinary tract infections occur, which maybe a woman had never previously had. And a lot of women do not recognize that urinary symptoms are associated with menopause, so it's really important that we explain this to them and let them know ahead of time so they know what to look for.
And then you talked about the sexual dysfunction that you may get with these symptoms. Can we talk a little bit to that?
Yeah, so in terms of the sexual functions, it can present for women in a lot of different ways. So, if you recall during my talk, I talked about the implications of a leaky bladder or dryness, where that can affect a woman's sexual desire. There are also women who report a decrease in ability to have an orgasm. And sometimes it can also just present with a lot of pain, both with insertion as well as penetration. So libido in itself is very complex. There's a very complex biopsychosocial model for why a woman may have a decrease in desire. But when it comes to the genitourinary syndrome of menopause, it can be one component of a decrease in libido.
And whenever we think about, certainly as a GP, if I'm going to do my cervical screening test on a postmenopausal woman, I will see an appearance that looks different than if I was doing a cervical screening on a younger patient. And that's because we are seeing a change even in the external genitalia. And that's hormonally driven, is that correct?
It can be hormonally driven. So it's very important that we as healthcare providers do offer a routine pelvic examination. And a pap smear, which in Canada is done every 3 years, starting at the age of 25, is an opportunity to do a pelvic examination so that we can look for not only signs of the vulvovaginal atrophy, but also is there maybe another dermatologic condition? Does that patient have lichen sclerosis? Is there lichen planus? Is there maybe a melanoma that we're missing? There's many other reasons why we want to be doing a pelvic exam as well. So that is one opportunity. But for women who may not be sexually active, or now they've had a hysterectomy and their cervix has been removed, or maybe they're in a same-sex relationship, those patients may actually lose the opportunity to have a pelvic exam with their healthcare provider. So it's on the onus for us to still request and still do that and explain to them the benefits of having that done.
And so let's talk a little bit about how we should be approaching genitourinary syndrome of menopause in terms of treatment.
So I'm not sure how guidelines are delivered here in Australia, but in Canada, we have the Canadian Menopause Society guidelines. And I think that if I look across the borders in terms of the North American Menopause Society, now called the Menopause Society, as well as the International Menopause Society, those guidelines are very similar. So I'm assuming yours would be the same.
They are.
In terms of first-line therapies, that we talk about the lubricants and the moisturizers, and this is really for patients who have very mild symptoms. So a lubricant to me is like providing providing some barrier to friction. And I often relate that to what we use on our face. So to me, a lubricant is like makeup on the face. You just use it episodically and periodically, either when you need to go out, you put makeup on, or when you want to be intimate. But really, lubricants don't change the actual physiology of the tissues. A moisturizer, and so lubricants are only used with intercourse. Moisturizers are used with or without intercourse, and it's the same thing as putting a moisturizer on your face. It provides moisture, and it can be used on a regular basis. But again, doesn't change the actual physiology of the tissues. And then in terms of the second-line therapy, which to me is actually first line because we know that lubricants and moisturizers only provide a very minimal amount of relief, is when we talk about the local vaginal estrogen therapies, which we have many of them. And so when I speak with patients, I really emphasize that there are a lot of different products that we have, and the best one that you should use is the one that you think you're going to be the most compliant with, because we want to help patients recognize that this is a chronic progressive condition. And so if we don't continue to treat it like we would high blood pressure or diabetes, her symptoms will progress. And so we talk about creams, we have ovules, we have inserts, we have a vaginal ring. And we also have a new product in Canada, which I believe is also available in Australia. It's called Progesterone, which is a vaginal DHEA as well.
When I see women in the menopausal transition, I witness many symptoms, including poor sleep, hot flashes, dry skin, low libido, weight gain, brain fog, and many more. But more than that, I see women who feel like they've lost themselves, and they tell me, I don't feel like me anymore. As a doctor with 25 years experience, I knew I had to do something. I wanted to incorporate all the knowledge I'd accumulated over the years, mixed with the most up-to-date scientific studies, to create a program where I could help women thrive. My Rediscover You program incorporates all the pillars that I believe you need to make this the best era of your life. Our program gives you 16 weeks of doctor support, and with the help of other health professionals, we will work hard to help you with your nutrition and weight, optimize your hormone health, put you on the path to the right exercise program for this stage of life, prescribe a skincare plan specific to you, and of course, provide you with treatments to pamper and improve your skin. We know that right now you feel exhausted and overwhelmed. Why not let us be your guide? Our goal is to help you regain balance, confidence, and joy for life, and help you take back control. This program gives you a one-to-one tailored experience, meaning we can only have a maximum of 10 women inside the Rediscover You program. To learn more and apply, head to youbydrShaunaWatts.com.au for everything you need to know, or click the link below in the show notes. Why have we moved towards something like progesterone with the DHEA rather than just the vaginal estrogen? What have we learned that we're needing to think about this?
That's a great question. So what we've now discovered is that we have both estrogen and androgen receptors in our vulvovaginal area. And when we look at the area, particularly where we have those receptors, we have more estrogen receptors inside the vagina and the vestibule, and the vulva, the clitoral area, actually has more androgen. And so when you are using a product that is addressing both the estrogen receptors as well as the androgen receptors, you're getting a better response in terms of treatment. Women also should be aware that when we are treating vulvovaginal atrophy and the genitourinary syndrome of menopause, we need to treat both the external tissues as well as the vaginal tract, because if you're treating the vaginal tract on its own, the external tissues will still not be adequately estrogenized from treatment, and they may still have ongoing symptoms.
So by that, you mean you're going to be using something internally, but then potentially putting a cream on the outside?
Potentially, depending on what you're using. With the vaginal DHEA, it is a small little, it almost looks like a suppository with an applicator. But when you put it into the vagina, interestingly, it has a hard fat around it, and that contains coconut and palm oil. So it's very, very moisturizing for the patient, and it does actually treat both the internal vaginal tract as well as the external tissues with one product. Whereas if you look at something like Vagifem, which is a small vaginal estradiol tablet that you put into the vagina as high up as you can go with the applicator, it really isn't addressing the external tissue. So at that point, you may need to add an extra form of vaginal cream to the external tissues.
And for anyone listening, how long would they need to wait to expect to see an improvement in their symptoms when we start using these vaginal hormones?
That's a great question too. And I think that's a really important question because sometimes patients think, oh, things are getting better and they're just going to stop. Every woman's a little bit different, and her level of compliance might also be different. And there's also levels of fear around around hormone therapy. So when we are providing that counseling at the time of the initiation of the prescription, we want to address their fears and reassure them it's a very safe product. We want to address the concerns around or their lack of compliance. And the third thing we also want to address is that black box warning that puts patients, again, at worry. So if we do appropriate counseling, they're more likely going to be compliant and they're more likely going to start seeing improvement. If you look at the studies, there are women who start seeing improvements even by 2 weeks. My clinical experience is that I give patients at least 3 months before they come back and give them the opportunity to get into a habit of using that product. So by the time they come back, they can actually tell me whether they're noticing an improvement or not.
What I find personally is sometimes people get a great response and then they sort of seem to run out of a bit of steam of using it. And I'll notice when they've maybe come in to see me for something else, I'll think, oh, you haven't had that prescription for quite some time. And they'll say, oh, yeah, I've kind of forgotten about that. Or, oh, it got a bit better, but actually maybe it's getting a little bit worse again. So can you explain, why and how we need to probably continue treatment?
So I, again, give patients analogies all the time because I think analogies and metaphors really help make things stick in their head. And so, I say to a patient, well, let's say you came to the doctor and you have high blood pressure and they put you on antihypertensive or, lower blood pressure medication, and now your blood pressure is normal. So you're checking it at home for 2 to 3 weeks and you're like, oh, my blood pressures are good. Does that mean you're going to stop your medication? No. And so I tell them it's the same thing with your vaginal treatment, is that if you are having concerns and you start therapy and things are getting better, it doesn't mean that you can stop. It just means that the therapy is working and you need to continue because this is a chronic condition. So that's kind of what I tell them.
Can we talk a little bit about women who have developed painful intercourse, that sex becomes very uncomfortable, and then they've kind of got into a bit of a fear cycle of having sex because really that just in their brain it is now that this is a very uncomfortable experience. So obviously we're going to go and try and give them some vaginal hormones, but what other techniques do you bring into play to try and get that woman to feel comfortable again with having penetrative sex?
That's a great question. So there's a couple of things that I recommend, actually 3. Of which one can sort of be clumped into one. So I really, really value the role of a pelvic floor physiotherapist, which now is becoming a lot more recognized in terms of their role in supporting patients. Sometimes they also talk about the use of dilators as well. And so I encourage patients to talk with their pelvic floor physiotherapist about the use of vaginal dilators and maybe show them how to use it. And, if it takes 5 years for you to start having symptoms, it sometimes may take a while for those symptoms to, be reversed. So this is a progress. It's not about getting to the end right away. I know some patients have a lot of embarrassment and shame and guilt around not being able to be intimate with their partners. And it's sort of this feeling of weakness. There's a fear around the word aging, and it's really hard for them from a psychological standpoint to come to terms with it. So working with a pelvic floor physiotherapist and giving them that confidence again with their ability to potentially have penetrative intercourse at some point is very valuable. The other thing I also talk to patients about is getting a sexual counselor or a psychologist who specializes in sexual health, because there can be maybe some history with a previous partner. There could be previous sexual abuse that we're not aware of. And so by addressing some of these concerns with a therapist and understanding the differences in desire, in terms of responsive desire, can also help a woman to feel more comfortable in the bedroom with her husband. The last thing is there is a book in Canada that we have, which is written by a psychologist who does a lot of research in sexual health. Her name is Dr. Lori Brotto, and she wrote a book called Better Sex Through Mindfulness. So I also encourage patients to read that book because a lot of comfort in having intercourse does have to do with being present and being mindful. And sometimes that gets lost. And so I also recommend that book to them as well.
Okay, amazing. And Shafeena, what about anyone who's listening who's thinking, well, I'm already on systemic hormones. I'm using a gel or I've got a patch, but I'm still having some symptoms. Like, do I need to use these vaginal hormones, or should my systemic hormones eventually work for this as well?
So systemic hormone therapy, which is, a patch and a progesterone or an estrogen, some sort of estrogen and progesterone if you have a uterus, and estrogen only if you don't have a uterus, can improve the symptoms of genitourinary syndrome of menopause, but 40% of women still need additional estrogen. And there are different doses of systemic hormone therapy, some of which are more adequate in treating the vulvovaginal symptoms and some of which are too low to get there. To those tissues. So I do encourage patients to be confident and comfortable with using an additional form of vaginal estrogen where we're specifically targeting those symptoms.
And what about a patient who is maybe a little bit on the older side? They've come through, unfortunately, maybe in that WHI era. They've kind of missed out on having hormone replacement therapy, and they've kind of been probably in the basket of, oh, well, it's probably no point in having systemic treatment, though that's obviously up for debate. But if you're 70 and you're having recurrent UTIs, is it too late to start vaginal hormones?
It's never too late to start vaginal estrogen therapy, which is such a great thing for me to be able to share with patients because there is such a fear around hormone therapy. But when it comes to vaginal estrogen therapies, we know through lots of excellent literature and data that the amount of estrogen in those products is so minuscule that there really isn't any significant systemic absorption. So if a woman was to start some form of estrogen therapy for her vaginal symptoms or urinary symptoms, did a baseline estradiol level, repeated it again at 2, 4, 6, 8, 10, 12, 1 year, the number would not increase. And so that really, really does give us as healthcare providers the comfort in telling patients that this is not going to cause a stroke or heart attack or a blood clot, that the amount of estrogen in these products are so low that they don't even enter into the bloodstream. And I'm not sure if you listened to my entire talk, but there was one clinical pearl that I've learned from one of my wonderful colleagues in Canada, where she compares the amount of estrogen to a birth control pill. And so she had said that if you look at the amount of, if you take ethinyl estradiol, which is the main form of synthetic estrogen in a birth control pill, and you convert that into estradiol, and you take a full year use of vaginal estrogen therapy, it's equal to a quarter of a single birth control pill. So when I tell patients that, they're shocked. And that really does help them understand how safe this is and how low of a dose it is, that there's that fear that I can really manage for them.
Yeah, absolutely. And I think the fear, to be fair, is not just among patients. I think, unfortunately, there's still lots of doctors and health practitioners out there who are quite fearful about starting hormones of any type and are still of the mindset that it's, for the shortest amount, the lowest dose for the shortest amount of time possible. But unfortunately, that, doesn't really serve women, because we know that the genitourinary syndrome of menopause is probably the one set of symptoms that just unfortunately continues to get worse as we go on this journey. Isn't that correct?
It's very true. And so this is why, as healthcare providers, it's so important that we address this with patients early on and then periodically. And it's hard as a GP. You and I live the same life where we have these very short appointments. We have so many screening parameters that we need to follow. Patients are becoming much more complex. Their needs are becoming more complex. So to talk about quality of life issues like menopause, like genitourinary syndrome of menopause, can be one extra thing that is added to our plate. And then when you go through 20 years of training or 20 years of being in practice where there's been no training on menopause, it can be even more cumbersome, because we as healthcare providers, GPs, need to know a little bit about everything. And hormone therapy and menopause is such a controversial area of medicine that it can be very daunting. And so, the little that we can do for educating our colleagues is going to do so much service for our patients, because we just fully can't see all of them ourselves.
Absolutely. And in terms of, if there was one message that you would love to get out there about this syndrome, what would it be?
One message. The message is that it's never too late to start therapy, and that the most important thing is to be aware. So when you have knowledge, you can make better choices in terms of seeking therapy and advocating for yourself. And by making better choices, you're going to have better results in terms of the treatment of your symptoms. So that would be my main message to all of your listeners today.
Amazing. Shafeena, you've been so generous with your knowledge. I'm going to ask you one last question.
Sure.
I ask everyone who comes on the podcast the same question, and it is, if you could give your 20-something self a piece of advice, what would you tell her?
Aging only gets better with time. I actually, I'm 42 now, and when I was 20, I was a very quiet, timid, scared, unconfident girl. And, as we get older in life, we become more confident in who we are. We begin to accept all of our flaws and our strengths. And I think it's a really wonderful time to celebrate. And I think as we get older, we become much more confident in who we are, and we thrive in all the areas of life that we've experienced. And I think our experiences define us and create us, and our imperfections are what we should celebrate.
Great. And that's true. And that means that for anyone listening who's in this kind of perimenopause or menopausal age group, the best is yet to come. Hopefully you are finding out who you are and you're that much more confident. And we just need to help you have that sort of physical and mental well-being so that you can go on to this next era of your life feeling fantastic.
I love that.
Thank you so much.
Thank you.
When I started this podcast back in December 23, I knew that I was lucky enough to have amazing conversations with various health professionals across all facets of medicine and allied health. And I knew that you would probably really enjoy being a fly on the wall to hear what we talked about. And that's how the podcast was born. And what you probably don't know is that this is a bit of a passion project. We don't have any sponsors or funding. And without your help, we won't be able to continue bringing you these great guests. So if you can please spread the word about the podcast, share it with someone who you think might benefit from the conversation that you've just listened to, or if you can leave us a review or a comment, it would mean the absolute world, because that actually helps the podcast spread further and get more people to hear our message and hopefully allow us to invite bigger and bigger guests onto the show. And I would so appreciate you helping me back. Thank you. This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.